Hello everyone. In this video, we will discuss about the coronary artery disease and diabetes. The coronary artery disease is the major complication of diabetes, and every year more than 50% of individuals with diabetes they die due to the coronary artery disease. We must also know that the diabetes mellitus and the coronary artery disease they share common risk factors as well as possibly they share common pathogenic mechanism, and this coronary artery disease is the factor which leads to development of premature MI in a patient with diabetes, and it is the leading cause of death in any patient with diabetes. Now let's discuss about the epidemiology of this coronary artery disease, which is also known as ischemic heart disease. And as per the American Heart Association, any patient with diabetes have 2 to 4% increased risk of deaths due to ischemic heart disease as compared to those patient without diabetes. As per one of the study which was conducted by the Lyon and Maddox, the relative risk of ischemic heart disease was found to be 1 to 3 in men and it was 2 to 5 in women. It means the relative risk of ischemic heart disease was little more as compared to the men in women, and this ischemic heart disease accounts for about more than 40% of deaths in any patient with diabetes. A retrospective study was conducted in which the patient with diabetes were included. However, these patients were not developed any kind of heart failure. These patients were followed up for up to 6 years, and after these 6 years, the study results demonstrated that the incidence of heart disease was quite high in patient with diabetes as compared to the patient without diabetes, and in the patient with diabetes the incidence of heart disease was found to be 30.9% per 1000 person years as compared to those without diabetes in which the incidence was recorded 12.4%. Now let's discuss about the risk factors of ischemic heart disease or coronary artery disease. So this coronary artery disease or ischemic heart disease is predominantly macrovascular in origin. Macrovascular means involving the large vessels including the coronary artery, and it is the leading cause of mortality worldwide, as well as this coronary artery disease is the leading cause of death among the person having type 2 diabetes mellitus, and it is also a leading cause of death among the type 1 diabetes mellitus. But along with the renal disease, it is found that the person with type 2 diabetes mellitus have 2 to 4 times more likely to develop macrovascular diseases as compared to those person without having any type 2 diabetes mellitus. It is also found that the Asian Indians have highest rate of development of coronary artery disease at much younger age as compared to the other counterparts. Apart from this, there are some other risk factors which can cause development of ischemic heart disease or coronary artery disease in any patient with diabetes. Those are hypertension, the obesity, and the dyslipidemia. Now let's discuss how this hypertension and development of coronary artery disease are interrelated. So hypertension in any patient with diabetes is often associated with the development of diabetic nephropathy, which is also known as diabetic kidney disease, and this diabetic nephropathy is characterized by the structural changes in the glomeruli of the kidney, increased filtration pressure, and the microalbuminuria means secretion of albumin in urine more than the normal limit. Apart from that, this hypertension also causes an activation of the renin, angiotensin, aldosterone system in the body, in the kidney. The activation of chronic RAS system, chronic renin-angiotensin-aldosterone system, causes damage to the nephrons in the kidney and ultimately progress to development of nephrotic syndrome. This nephrotic syndrome is characterized by proteinuria, secretion of protein in urine more than the normal limit, the development of procoagulation state, and the development of hyperlipidemia, the increase in the amount of the abnormal lipids in the body. This condition of hyperlipidemia causes increase in the risk of development of cardiovascular diseases, including the ischemic heart disease. Now, let's discuss how the obesity and development of coronary artery diseases are related. So, in any patient with diabetes, the insulin resistance is common, and both these diabetes and insulin resistance are associated with the overexpression of these cytokines by the adipose tissue and the excessive lipid accumulation. This overexpression of the cytokine affects the blood vessels in the body, including the coronary arteries, and it causes the endothelial dysfunction, the development of myocardial infarction, as well as the development of cardiomyopathy. And all these factors have deleterious effect on the coronary vasculature, and which ultimately leads to development of coronary artery disease. Now, let's discuss the relation between the dyslipidemia and coronary artery disease. As we know that in any patient with diabetes, there is development of dyslipidemia from insulin resistant fat cells, which causes the increased release of free fatty acids in the body. Apart from that, in any patient with diabetes, there is increase in the level of glucose in the body, which causes abnormal lipoprotein levels. This abnormal lipoprotein levels results in dyslipidemia, and this eventually causes the aggressive atherosclerosis in the body and ultimately contributes to high prevalence of development of ischemic heart disease or coronary artery disease. Now, let's discuss the pathophysiology of coronary artery disease. The major substrates in development of coronary atherosclerosis in any patient with diabetes are the impaired glucose metabolism and endothelial dysfunction, and both of these conditions are caused by the inflammation and by the oxidative stress. Apart from that, there are few other factors which also cause the arterial changes, which includes the increase in the blood glucose level, the development of insulin resistance, and increase in free fatty acid as a result of dyslipidemia. Here in this diagram, we can see that the arterial changes are caused by the inflammation of the blood vessels, which also causes the increase in secretion of factors like cytokines and adipokines. All these factors leads to development of hypertension as well as dyslipidemia, which results in development of ischemic heart disease or coronary artery disease in the body. Here are the few factors which accelerate the development of atherogenesis in diabetes. This includes the abnormalities in apoprotein and lipoprotein particles, the development of uncontrolled BP or hypertension and abnormality in the blood glucose level, the glycosylation and advanced glycation of proteins in plasma and arterial wall, the glycooxidation and oxidation process, the procoagulant state which develops in any patient with diabetes, the development of insulin resistant and hyperinsulinemia in any patient with diabetes. Apart from that, the smooth muscle proliferation and foam cell formation, which are the part of development of any atherosclerosis process, are also enhanced by few hormones, few growth factors, as well as by the development of cytokines. Now, let's discuss what are the clinical presentation of CAD or coronary artery disease. So, it can present like a stable angina. Stable angina is also known as typical angina or angina pectoris. It is a symptom of myocardial ischemia, and the stable angina is characterized by the chest discomfort or anginal equivalent, and this is provoked by the exertion and elevated at rest or with nitroglycerin. The second clinical presentation is unstable angina. The unstable angina is the chest discomfort or pain caused by an insufficient flow of blood and oxygen to the heart, and it is also a part of acute coronary syndrome in any patient with coronary artery disease. The third clinical presentation is known as variant angina. It is also known as Prismental's angina, and it is a clinical condition characterized by the chest discomfort or pain at rest with transient ECG changes in the heart in the ST segment, and it gives prompt response to the nitrates. The fourth clinical presentation is acute myocardial infarction, also known as heart attack, and this acute MI is a deadly medical emergency where the heart muscle begins to die because they are not getting enough blood flow. Now let's discuss what are the peculiarities of presentation of coronary artery disease in any patient with diabetes. So, development of coronary artery disease in any patient with diabetes may be silent, or it can be present as atypical presentation like angina equivalents. This coronary artery disease can occur at younger age in any patient with diabetes. It can also involve the small vessels, selectively known as microvascular angina, and there can be also diffuse and multiple vessel involvement also in such coronary artery disease. And the complication of acute myocardial ischemia is very common in CAD in any patient with diabetes, and this has very worse outcome even after the revascularization procedures. So, what are the indicators for screening of coronary artery disease in any individual with diabetes? If any person develops any typical or atypical cardiac symptoms like unexplained dyspnea or chest discomfort, the screening can be performed if the resting ECG, the electrocardiogram, suggests the features of ischemia, the low level of blood flow in the heart, or myocardial infarction like development of Q waves in ECG. Other indications for screening are development of signs and symptoms of any cardiac disease like carotid bruit, the development of stroke or transient ischemic attack, any claudication or any peripheral arterial diseases. Now let's discuss what are the modalities which can be used for screening in any patient with coronary artery disease. So the first one is exercise stress test. It is also known as cardiac stress test, and this cardiac stress test it is a cardiological test that measures the heart's ability to respond to external stress in controlled clinical environment, and the stress response in this test can be induced by exercise or by intravenous pharmacological stimulation, or in some cases we can use the combination of both these exercise as well as the pharmacological stimulation. But this exercise stress test or cardiac stress test can not be useful in asymptomatic patients. The second modality for screening is cardiac CT. The cardiac CT scan is a non-invasive painless test that can evaluate the heart and the surrounding blood vessels to identify any kind of blockages or narrowing in the arteries, and it can detect any problem with the pumping function of the heart, which may indicate some possible heart disease that can be a coronary artery disease. And the cardiac CT, if the findings of coronary calcium score is more than 400, so this indicates that we can use some other testing mechanism for screening. The next modality is PET scanning or stress echo or cardiac MRI. This PET scanning or positron emission tomography of heart is an imaging technique that uses a radioactive substances which is known as tracer to look for any disease or poor blood flow in the heart. Apart from that, the clinical judgment can also be applied for screening to decide any advanced cardiac evaluation. Now let's discuss what are the diagnostic method of coronary artery disease. So diagnosis of coronary artery disease includes the preclinical method and the clinical methods. The preclinical method includes the biochemical marker assessment, the assessment of functional changes, and the assessment of structural changes. The biochemical markers measurement includes measurement of lipids, the lipoprotein A, homocysteine, C-reactive protein, and fibrinogen. The assessment of functional changes include checking of any endothelial dysfunction, and the assessment of structural changes include observation of any intimal medial thickness. In clinical methods, there are two sub-methods known as biochemical markers and the measurement of resting ECG, the TST test, that is thrombin heparin tolerance test, the ECG electrocardiogram, the echocardiogram, and stress thallium scan as well as angiography. The biochemical marker measurement include the CKMB assessment and the troponin test. So what are the major goals of treatment of any coronary artery disease? So the first major goal in treatment of coronary artery disease include increase in the coronary artery perfusion, mean maintenance of the flow of blood in coronary arteries. The second goal is to decrease the myocardial workload so that heart can pump the blood very smoothly. And the third major goal is the prevention of development of any myocardial infarction, means any ischemia or necrosis in the heart, and development of any disability or death in the heart muscles. Also, the other major goals of treatment is intervenence or treatment in any case of development of unstable angina. Now let's discuss what are the management methods for ischemic heart disease. So for that, we should follow the American Diabetes Association recommendation. As per these ADA recommendations, in any diabetic patient who is not having any kind of symptoms, we need to do the frequent screening for any ischemic heart disease or coronary artery disease. If any patient with diabetes develops any atypical cardiac symptoms, in that condition we need to investigate for development of any ischemic heart disease. If there are some signs and symptoms of vascular diseases in any diabetic patients, in that condition such assessment of signs and symptoms can be done by observing or supervising any carotid root, development of any stroke, any peripheral artery disease, and to check any ECG abnormalities in such patient. In any person having diabetes is more than 40 years of age, so as a part of cardiovascular risk assessment, we need to check for the coronary artery calcium and we need to do the management for the same. As a initial diagnosis, we need to obtain the exercise ECG testing initially and after that annually. Apart from that, we need to also assess some independent risk factors for the development of any ischemic heart disease, which include the screening for dyslipidemia, abnormal lipid level, abnormal lipid metabolism. We need to also assess or also detect for hypertension. We need to measure the waist height ratio for the assessment of any obesity. Apart from that, we need to detect the microalbuminuria, the checking the level of albumin in the urine, which indicates the development of diabetic nephropathy or diabetic kidney disease. Let's discuss the treatment modalities for the ischemic heart disease. In any patient with diabetes who has developed or diagnosed with atherosclerotic cardiovascular disease, as per the ADA recommendations, the American Diabetes Association recommendation, in such patient we should either use angiotensin converting enzyme inhibitors, AC inhibitors, or we can use angiotensin receptor blockers, ARBs. This treatment, pharmacological treatment, should be initiated with combination of lifestyle changes and prescribing metformin. After that, we can also other drug to reduce the major cardiovascular events. So, in such condition, we will combine the canagliflozin along with the metformin to reduce the cardiovascular events. In any patient who has already developed myocardial ischemia, in such condition, we can continue prescribing the beta blockers after the 2 years of the events. In any diabetic patient, especially the type 2 diabetes mellitus who has developed the stable congestive heart failure, in such condition the metformin can be prescribed, can be recommended, but metformin can only be prescribed when the glomerular filtration rate is more than 30 ml per minute, and we should avoid prescribing the metformin if any person has developed unstable congestive heart failure. Now let's discuss the recommendations for the screening and treatment in any patient with CAD or ischemic heart disease. All the asymptomatic patient with diabetes should be evaluated for the risk factors for development of any coronary artery disease. Any patient who is known case of coronary artery disease should be given AC inhibitors or angiotensin receptor blockers along with statin and aspirin if such patients are not contraindicated for such medications. If any patient has already developed myocardial ischemia, in such condition we can continue prescribing beta blockers for 2 years after the event. We should strictly avoid the thiazolidinediones and saxagliptin in patients who are symptomatic with heart failure. The SGLT2 inhibitor drugs are the anti-diabetic agent of choice in such patients of CAD, which can improve the outcome in any patient with the heart failure. Let's discuss the condition of heart failure in any patient with diabetes. So, type 2 diabetes mellitus is a risk factor for development of heart failure, and this heart failure can be of two types: the heart failure with reduced ejection fraction as well as the heart failure with preserved ejection fraction. So, the type 2 diabetes mellitus is risk factor for both kind of heart failure, and this development of heart failure risk increases with increasing the age. The older age has higher risk to develop the heart failure. Apart from that, the concomitant coronary artery disease or peripheral artery disease or any development of neuropathy, retinopathy, if patient is obese or already hypertensive, in such kind of cases the risk increases for the development of heart failure, and it is found that the clinical outcome of heart failure is worse in the patient with diabetes as compared to the person who are not having diabetes. There are different classes of drugs which has different effect on the heart failure. The metformin, sulfonylureas, insulin and GLP-1 receptor agonists have neutral effect on the heart failure outcomes. The drugs like thiazolidinediones and some DPP-4 inhibitors like saxagliptin and alogliptin, they are associated with adverse outcome of heart failure. So, such kind of drugs should be avoided in any patient with heart failure. The third class of drugs are SGLT2 inhibitors, and these drugs can improve the outcome in any patient with heart failure. So, the SGLT2 inhibitor are the anti-diabetic drugs of choice in any patient with heart failure. So what are the management methods in any patient with diabetes who has developed acute myocardial infarction? So in such acute episode of myocardial infarction, we should avoid all the oral antidiabetic agents, including the metformin, as it is usually not recommended in such acute episode of MI. We should try to maintain the blood glucose level around the 140 to 180 milligram of per deciliter. We should start insulin in such acute episode if the level of blood glucose is above the required threshold level. In insulin, we should think of starting short-acting insulin. Once the patient is stable after this, then we should shift the patient on any insulin regimen or any oral antidiabetic drug-based regimen. If the medical therapy is failed in such kind of patient, we should start thinking about the revascularization therapy, which includes the PTCA, stents and CABG. The PTCA, the percutaneous transluminal coronary angioplasty, which is also known as percutaneous coronary intervention. It is a minimally invasive procedure to open any blocked or stenosed coronary arteries by using a balloon tipped catheter which flattens the plaque and opens the artery. The second method is stenting. So in this, a small metal mesh tube is inserted into the coronary arteries, and it is performed only after the or immediately after the angioplasty. This metal mesh tube properly opens the clogged artery as well as is also prevent the artery for closing up again. The next method is CABG, coronary artery bypass grafting, which is also known as heart bypass surgery, and it is a medical procedure in which a different blood vessels from another part of the body, usually from the chest, leg or arm, is taken and it is attached to the coronary artery above and below the narrowed area or blocked area. It is found that the long-term outcome is worse in any patient with diabetes as compared to the patient without diabetes. It is also found that there is no long-term differences in outcome between the procedure PTCA and the CABG in any patient with diabetes. Now let's discuss the primary prevention when only risk factors are there. There are no development of disease. So this primary prevention is not for all the patients who are with diabetes. The aspirin therapy as primary prevention can be considered in the diabetic patient who are at increased cardiovascular risk. So the use of aspirin therapy as a primary prevention strategy can be think of for such kind of persons. However, in a patient with age more than 70 years, the use of aspirin as a primary prevention method can be little difficult, little dangerous, as it contains greater risk as compared to the benefits of using aspirin in such patients. The other primary methods which can be used, primary prevention method which can be used for the patient with diabetes are the achieving the lipid goals by using moderate to high intensity statins, which can help in achieving the non-HDL and HDL cholesterol levels in any patient with diabetes. The another primary prevention method is the achieving the required threshold blood pressure level. The secondary prevention methods in any patient with diabetes means in which the patient has already developed the coronary artery disease can include the use of antiplatelet therapy, use of beta blockers, the angiotensin converting enzyme inhibitors, the statins. Apart from that, we can also use the SGLT2 inhibitors and GLP-1 receptor agonist as a secondary prevention methods, which shows some cardioprotective effect in such kind of patient, and that's why these are the anti-diabetic agents of choice in any patient with cardiovascular diseases. So, what are the strategies which can be applied in any patient with coronary artery disease for the reduction of the risk for further development of any complication or sequelae? So, it includes the 10-point formula. The first one is early diagnosis of diabetes. The second is good control of diabetes. Third is control of dyslipidemia. The fourth is control of BP. Fifth, the use of aspirin when indicated, when needed. The sixth is modification in dietary habits. The seventh is use of exercise, which can be mild to moderate or moderate to severe. The eighth formula includes the reduction of the weight. Ninth is quitting smoking, and the 10th is use of relaxation techniques, which includes yoga, meditation and other methods. Now we have come to the end of this discussion. So the ischemic heart disease is the major risk of all cause and cardiovascular mortality in any patient with type 2 diabetes mellitus. There are few risk factors which contribute in development of ischemic heart disease in any patient with diabetes. Those are hypertension, obesity and dyslipidemia. There are few other factors which causes the arterial changes in any patient with diabetes. Those factors are increase in blood glucose level or insulin resistance and increase in the level of free fatty acids. As per the American Diabetes Association recommendation, in any patient, diabetic patient without symptoms, we should apply the frequent screening for the ischemic heart disease or coronary artery disease. The management of coronary artery disease or ischemic heart disease includes the initiation of pharmacological treatment along with the lifestyle changes, administration of the metformin and use of some other pharmacological agent like angiotensin converting enzyme inhibitors or angiotensin receptor blockers. Hope you have liked this video. Please like and share this video with others. Thank you.